Our next speaker, who I had not had the privilege of meeting until today, I saw him wandering around a few times because I saw his picture, so I knew who he was all about. And you're so keen. Come on up too, Gary. So this is Dr. Gary Schwarz. Hello and welcome.
Thank you.
Now, what I learned about Gary is that he's also Seattle Study Club director. We've been one for 8 years, he told me. But this is actually his first symposium. Now, isn't it an amazing experience?
Bad boy, they had to get me to speak to get me here.
That's right. So from now on, it's every year.
That's right.
To see you here. Okay. Now, he's also going to talk to us about a challenge that none of us know anything about, the issue of periimplantitis. And I look at it as, even the diagnosis, the recognition and the diagnosis of periimplantitis is difficult. Even the literature we read is a little bit confusing in that whole realm. And then when a lot of us would go into treat it, we talk about we're going to throw the kitchen sink at this thing, right? Because we honestly are challenged by it. So please enlighten us and help us understand how to manage it. Okay?
All right, we'll give it a try. Well, welcome everyone. It's like all have said, it's an honor and it's humbling to be chosen by Dr. Cohen to be a part of this. And in my case, it's even more so because let's face it. I mean, if you wanted to vote on the most unknown of the 25 before today, it would have been me. I mean, I'm a newcomer to this. I've been out there like you guys, a wet-fingered dentist, just trying to better myself for the years. I never planned to do this, and it's crazy to me how it happened. Where's the? Here we go. It's a miracle that I ended up here, and because I certainly didn't set out to do this. In my life, I had other goals and other plans my whole life, and I need to talk to you about periimplantitis, but I also need to go back and kind of tell you my story of what led to me being here. Because in telling that story, it gives proper credit where credit's due to Dr. Cohen and this Seattle Study Club genius thing that he started, because it has changed my life. Not just brought me here, but it has changed my life. So I got to go back to the beginning, which was the Rio Grande Valley of South Texas. It's down here at the very tip of Texas, where Texas touches Mexico, separated by the Rio Grande River, bounded on the east by the Gulf of Mexico, with the towns of South Padre Island and Brownsville, and to the west at Roma, Rio Grande City, in the western aspect of the valley. The distance between the two is around 120 miles. Today I have offices in McAllen, which is on the western side. That's my main office. But I also have satellites strung out all the way to the coast, Weslaco, Harlingen, Brownsville, South Padre Island. But it didn't start that way. That was not the plan, because I grew up in the middle of the valley on a farm, and I fell in love with farming. I loved it. But I also loved the ranch that my family owned further to the west, where there was no irrigation and it was more arid, and there the woods were still there and the wildlife was there. And I was really inspired by the wildlife. I was touched by the fact that the wildlife was gone in the middle of the valley because it had all been cleared to do the irrigation farming. And so my goal in life was to become a farmer, buy a ranch, and farm for deer to make the deer better by feeding them better. That's crazy, I know. That was what I wanted to do. And I was going to preserve, protect, and enhance the land and the wildlife on it. But Daddy was smarter than me, and he said, son, there's no money in that, but you're smart, you do well in school, so go be a doctor or a dentist, and then come back and work hard, and then you can do that for fun on the weekends. It can be your hobby, not have to depend on it for a living. And that was in the 8th grade. And so 4 years later, I headed off to Baylor in Waco, and 12 years later, I came back from Baylor in Dallas as an oral maxillofacial surgeon, set up my practice, and began attacking the goal of becoming the best in my area, getting successful, getting busy, and providing the funds to do my dream. And at the end of year one, I was off and running. I was able to buy the first 1,000 acres and started my own research, figuring out how to grow crops to enhance the deer. And 6 years later, I had found a solution with a seed I found from Africa via Australia, and technology I learned on how to farm dry land, and inventing a reversible fence to hold the animals off long enough to get them established. And our deer just exploded. And then 6 years later, after publishing about 40 articles, including 3 research papers and published in peer-reviewed journals, the world discovered it, and my office got inundated with phone calls. More phone calls for these crazy seeds and wisdom teeth and implants, and my staff said, Doc, you got to do something. So we started a wildlife seed company and a TV show with Jeff Foxworthy as our our first co-host, and it became #1 on the airway, on TV. And it's still there. It's not #1 anymore, but it's just been like living the life of Riley, having these dreams come true. And then about 14 years ago, I had another opportunity to buy a piece of property west of there, closer to Laredo, closer to the river, with irrigation on it. And so my other dream was to grow bigger fish, and so crazy, right? So I started digging. I've been digging for 14 years, and now having some dramatic results there. I found a new forage to grow these big old bass, and this is from May. It says the plan to return the bass record to its homeland, and inside it says this man is trying to bring the largemouth bass world record back to the USA, and it's working. And here's in the article. This is a lake that I built, and up above it you see those higher forage ponds, and I found this new forage, the first new forage in 100 years. It's called an Indonesian prawns. They grow from like a little bitty, like 4 millimeters to that size in just a few months, and the bass just love them. So, you know, that was my life before. I had no plans to do anything else. I was never driven to become known in oral surgery. I'll be honest with you, when I was a resident and early on in my practice, my view of most oral surgeons was that they were cocky guys that I didn't care about that much. I've since learned that I'm wrong. There's a lot of really nice guys. But that was my view of the world back then. And the other part of my life was my family. And this woman you see to my right, beautiful wife of 43 years. And we've been together for 50 years because we started dating when I was a freshman in high school. And she loved the habitat, loved the land, shared all the things I shared, and she was an incredible mom, raised 3 wonderful kids. Like Michael Pico said, they've never given me a lick of trouble, and it's because of her. And 6 wonderful, beautiful grandkids, and our lives revolve around the ranch. It's the center of our world. But the center of our universe is our Lord, who has blessed us in spite of myself by His grace. And so that's where I was up till about 8-9 years ago, when my Nobel Biocare rep approached me about the Seattle Study Club. And I was initially, no, I don't have time, and I tried the other Seattle Study Club way, and it hadn't worked. And he said, well, this is different. You need to talk to him on the phone. And so I talked to Greg, and Greg inspired me because I saw the discipline and the coordination behind it, and mainly the treatment coordinator who would be trained to run it for you. And so against the wishes of my wife and my office manager, who said I did not have time, I said, okay. So I started Seattle Study Club in South Texas. We hit the ground running with the 2nd largest club in the country, from what I was told. And little was I prepared for how it would change my life. Because little did I know that within a year, I would have the attack of my life on my practice. And my very ability to practice at stake. But those members were there every month that I would have to go, be there with them, and they would love on me and pray on me and get me emotionally through it. But beyond that, what happened in my practice was amazing. I mean, I've been stuck on 300 to 350 implants per year. And year 1, it doubled. Year 2, it doubled again. And that's the good news. Well, what's the bad news? The more implants you got, and of course I've been stockpiling them for years, patients I've treated, the more peri-implantitis you're going to have. And so I started treating them, throwing the kitchen sink at them, I tried everything. And I was so discouraged by the results. And it was so stressful to me and sad to me to do this beautiful work and have it come back, spitting pus and blood, and losing them. It just made me cry. And so one night I decided to give a talk to my study club on peri-implantitis. So I reviewed the literature, and it made me feel good that I found the same stuff in the literature that I was experiencing. I wasn't doing anything wrong. But the worrisome thing was nothing was working except for on peri-implant mucositis. And I had an answer for that. Unscrew the cover screw or the healing cap, wash it with chlorhexidine rinse, put a pledget of arrestin in there, and put the screw or the healing cap back on, and it's going to cure it. But when it progressed to bone loss with peri-implantitis, that was a different animal. So what did the literature say about it? It said, first off, that the link between periodontal disease and peri-implant disease is the same. It's the same bugs that cause both. But what about treatment? Well, the first big review paper was from the European Perio Workshop Conference on peri-implant disease, chaired by Lindy. And they came up with this list of everything that had been tried, and nothing worked. Interestingly enough, look at number 2. Some promise with laser therapy, but it needs further study. And that night, that's exactly what I told the guys. I said, the only thing I've seen any help with is, or any positive look is some interesting tissue response to a laser. And it was an inexpensive diode laser, and it doesn't fix it. But I saw some positive things, just like what you see here. And so before I tell you what happened next, let's look at a couple other review papers. This is 2012. This is Algraphy's paper. Again, looked at all the different treatment options, no clear choice, and high failure rates. Following that in 2014, this was not the night that I gave the talk, because the talk was in 2012. But Algraphy's 2014 paper reviewed everything. Non-surgical treatment, surgical treatment, found the same thing. Nothing is working consistently. Now there's a scattered positive effect reported here and there, but nothing is working to the level of statistical significance. Nothing. So I'm walking out with my coordinator, and this dentist comes walking up to me that I respect tremendously, and he says, Gary, have you checked out the Millennium Laser? I said, oh, what? That sounded like a spaceship to me. And he said, you know, the LAPIP. I said, that's like Greek. I had no idea what he was talking about. But he said, listen, he says, you're a hunter. He says, it's like comparing, what you're using is like a pop gun compared to a laser-guided smart missile or whatever. He said, there's no comparison. And so the next week, my coordinator gets the rep down there, and he shows me this information, the scientific information behind this thing, mainly on teeth. I saw the paper from Martin Evans, and I saw bone growth back around teeth, where I never saw any of the periodontists in my area do that with a knife. Never. I saw bone growing around teeth from Ray up this paper. And then I saw some selected cases showing some things happening on implants that I haven't been able to do. So I said, I mean, it's not cheap, but I said, I want it right now. He said, Doc, you gotta go get trained. You can give me a $5,000 down payment, but you gotta go pass the laser boot camp. Let me tell you, it is boot camp. I had studied that hard since dental school. Reams and reams of articles and information on the physics of lasers, and it's very impressive. It's intense training that's required, and it's essential to do that. I want to go back and train again because I forgot so much of that stuff that I want to know. And I mean, it's truly amazing. And I was going to spend time going through the different steps of how it works, but I don't have that time to do that because I got to get through the rest of this material. But you don't need to know it now, because even if you want to get it, you can't get it till you pass the course, and that's the way it ought to be. So implant, are you probe or you're not probe? And this is a really important question, because I tell you, one of the surgeons that I most respect has taught me tons of stuff. I won't mention his name, but he still to this day says don't probe. But if you don't probe an implant, how are you going to diagnose periimplantitis? Can you get it from a radiograph? Well, you might say you could get it if you had a tomogram, and when I started this, I didn't have a tomogram in my office as I do now. But I would submit to you this. When I do orthodontics and I go in there and I flap the maxilla, so often the roots will have been pushed orthodontically out of the bone. So the buccal aspect of the roots have no bone on them. If you did a tomogram of that, and you use that to define periimplantitis, there's no bone there. But is there a pocket there? No, you put a probe in it, it's tight. You can't get past 2 millimeters most of the time. Does it get disease later? Usually not, except in lower anteriors. That does happen because you get the stripping followed by the disease there. But it's a different kind of disease like the normal perio that we talk about. And I would submit to you the same thing is true of implants, because so often, you know, it's that buccal wall that you lose. In fact, this periimplantitis study has got me putting in narrower implants than I used to put, because I used to want a good emergence profile. Now I want to get that implant away from the buccal plate as far as I can. But once that bone is gone, you're not going to get it back, even if you cure the pocket. So what's important? Having bone around 4 walls, or having healthy periodontium around 4 walls, and enough bone to keep the implant stable. But anyway, no, I don't think certainly 2-dimensional x-rays, you can't see it unless both buccal and lingual walls are gone. Now, if you press on the tissue, and I use this to check my progress between periimplantitis treatment and when I'm going to probe 6 months later, I'll push on the tissue. And if I see blood or pus after the first treatment, I'm going to come back and not wait. I'm going to treat it again. But that doesn't allow you to quantify. The only way to truly diagnose and quantify is to probe. And literature defines periimplantitis on the basis of probing anyway. This is the definition. Any pocket 5 millimeters deep or deeper, or any 4 millimeter pocket that bleeds. That is periimplantitis. So that became the standard for which I would treat. So I began treating them, and this first case shows you a clear example of how the periapical, or the Bible, it doesn't show much in terms of bone, because it's a defect on the buccal plate, and the lingual plate's intact, and so you can't see it. It's hid by the lingual plate. But look at the pockets there. I've got 5, 8, and 5 on the buccal, and 3s on the lingual. Treated one time with 160 joules of energy, 166 on the first pass, 94 on the second pass. 6 months later, I have healthy implant, and that hasn't come back since. That was 2014. This one's got bone loss buccally and lingually, and I wasn't even going to treat this one. To me, this was gone. The implant on the right side this is an overdenture on locators. The implant on on one side was perfectly fine. The other side is bombed out. And I said, I need to take this out and put your new one in. I was going to put one right beside it. He said, Doc, I'm going on vacation. He said, just do that laser treatment you were telling me about, and to cool it off, and when I get back, you can take it out. Well, that implant is still in years later, one treatment, and we were done. This is another example, just showing you the same thing. In the interest of time, I got to move on. Another example, this case took 2 times to treat it. It had both pockets up in the gingival area, but it also had like a periapical abscess draining through to the labial. And first treatment worked, but not fully, and so we ended up having to treat it again to treat that case. This is an example of a failure. This case was treated once, it got worse. Treated a second time, it got worse. Treated a third time, it got worse. I said, the implant needs to go. This guy's 90 years old. He said, Doc, he said, how about if I just come every 3 months? Because you treat it and it would be better for 3 months or so and then relapse. And so he's in a maintenance phase doing that. And you'll see the data in here in a minute that shows us what normally happens. Now let me show you a cool case. Here's a case I did in 2007, took the teeth out. You see the Carl Misch influence on my life. I put immediate implants in. This is not guided. It was immediately provisionalized, and later final crowns were done. But it's an accident waiting to happen because the upper is not done, cross arch stabilization. You got 4 bridges up there, crown and bridge. I planned on crown and bridge on the bottom, but he's not one of the better dentists I work with. For some reason, the lab, they went with a bar clip. I'm not a bar clip, but a fixed hybrid, and there's not vertical room for it. And so they had to cast directly to the implants. The fit is poor. And although it was a decent result, the cosmetics is not great, the teeth are too short, the color is bad, but she was thrilled. And for 7 years, she was asymptomatic, no bone loss. And then in 2014, she came in, she's blown up on the anterior and in the posterior, and terrible bone loss. And so I told the dentist, those top 13 and 14 are gone, they're just floating granulation tissue. So they cut the abutment and send her back, take off the lower. You see the traumatic occlusion that it caused all this, and by the way, that's what I found is number 1, more than cement, is traumatic occlusion. You can see it's pussed out on the bottom. I treated it, and you see before on top of the sickness and redness and swelling in the tissue, and this is 7 months later on the bottom. Here's a remarkable change in the panoramic radiograph. Here's the periapicals that show it. You see the charting change, the reds on top and the absence of the pockets on the bottom. This is 2014 on top, which are not very good bite wings, but you see on the bottom how the bone has remained through 2017. And here you see the day of surgery on top, and then on the bottom, in top left, you see the healthy tissue. Now there's some redness there because one of the things I did wrong, this was early on, I didn't put healing caps on before I delivered the energy, and so I did some laser pitting of the surfaces that caused some redness, but there's no periimplantitis. The disease is gone. So I decided it was time to do a retrospective report. That was a recent paper that Nicholson did in 2014, but it didn't really, it was 16 of the ideal cases, and it was a fantastic result. What was needed is a bigger group. So I hired David Harris to help me do a retrospective study, and this is what we came up with. We had 222 patients from October 2013 through 2016 when we gathered our data. And among them were 442 implants or so. But we had complete data on 116 patients with 224 implants that we were going to write our paper on. The difference in data between the larger group and the smaller group was essentially the same. And what it showed was that rescued implants from the first treatment was 79% success rate. That was defined as eliminating the inflammation shown by redness, bleeding, or pus, and shrinkage of the pocket to 4 millimeters in 6 months. 18%, well, 3% failed and had to be removed. 18% went on down to second treatment, of which 11% were successfully treated. 0.4% failed, and then you see 7% were treated 3 times and considered a hopeless case, but just in maintenance to keep them there when the patients want them. The statistical analysis showed that for reduction of probing depth, it was statistically significant to a p-value of 0.001, less than 0.001, awesome. And it was true also of the inflammatory markers. In summary, the impact on my practice is the first protocol that I know of and that the literature reports on. And this isn't reported yet because we're having trouble getting reported. I'll tell you that in a minute. First protocol with high probability of success. It doesn't involve a long, expensive, or painful surgery. There's minimum negative sequelae. You need to tell the patient that when the laser energy is delivered, some patients absorb that light more than others based on the color of their tissue, and it's unpredictable. I had 3 patients with minimum soft tissue death, attached gingua, with exposure bone. 2 of those had a small sequestrum develop, but they all resolved with successful outcome on the peri-implantitis. It gives me hope, gives my patient hope. It's less stress for all of us, and it's been a major practice growth for me because I'm the only guy in the whole valley that can treat peri-implantitis. So it has brought me referrals that weren't referred to me before because their guys can't fix it. Look at the numbers. I treated 15 in 2013 in the last 2 months, last 2 months of the year, first 2 months that I was using it. And then look how it grew through 2016, 305 implants. But look what happens in 17, the bottom fell out. What's happening? It's being successful. It's being successful. Challenges remaining is the 10% failure rate, the percent reinfection rate, and getting the study published. I sent it to the Journal of Oral Surgery. That's where I wanted it. They didn't even consider it. They rejected it because a single investigator retrospective study with success rates too high to be believed. We've got it now with the Journal of Oral and Maxillofacial Implants. It's been there for 5 months. David Harris finally called them and said, look, if you aren't going to look at it, send it back to us. They said, well, it's going to be 3 or 4 months. They said, send it back, because I've got other journals that are willing to publish it. We just were trying to get it in a premium journal. They called the next day, said, we're looking at it. So we'll see what happens. Further studies needed, and I'm finishing up real quick, is the better duplication of radiographs to prove bone growth. That's the cone beam. I have that down, but like I told you, I don't think we're going to see bone on the labial once it's gone. There's no architecture scaffolding to guide the regeneration of bone. What's important is a healthy pocket that doesn't bleed, doesn't spit pus, and it's not getting worse. We need long-term follow-up to figure out what the rate of reinfection rate is, because I'm seeing some healthy treated cases that are relapsing, so we got to look at that. And like I said, learning what's causing the pocket to shrink. Speaking of causing something to shrink, this is me 4 years ago. I got feeling so bad that I went to the doctor. He said, you're a physical wreck. You got to lose some weight. I said, I can't. He said, well, eat less, work out more. I said, I can't work out because of my car wreck that crushed my pelvis. It causes me chronic pain. I can't eat less because I can't. I tried. He said, well, do this for me. If you can't do it for me, for you, do it for me, make me proud. Because I know that's what makes most docs happy, be docs. It starts with making their parents proud with their report card, then their coaches or their teachers proud, then your patients proud. So make me proud, come back a different man. So that's me in October of this past year at St. George, Utah at the World Senior Games. And I won the senior medal in the long jump. That guy's if anybody gonna beat me and beat young, I'm proud to be beat by him. He won 5 gold medals and set 3 world records in our age class. He beat me on his last jump, by an inch and a half. God, I hate being second. I'm going back next year though. Thank you all.
Thank you very much. All right. So it's a challenging area. We have some experts in the audience right here, even in our first row on the peri-implantitis thing. To probe or not to probe should not be a question, although some people still like a battle on that one. There's a lot of questions in this whole area. We still need better research is the bottom line. And we have all individualized experience, but there's no consensus still. But there's some interesting opportunities out there. So with that, we bring ourselves to the last section before our little break.